First of all, I would like to thank Sanjay, Michael, and Steve for inviting me again here this year for these very interesting and successful conferences on sport cardiology in London. So my task today is to address the problem of differential diagnosis between chamber dilatation versus cardiomyopathy. At the start, refer to the physiological adaptive changes of the heart to regular training and competition. These changes include structural changes of the heart that are characterized by an increase of ventricular mass both in the left and right ventricle due to increase of both cavity dimension and wall thickness. Functional changes, that means normal diastolic filling pattern, preserve, this is very important, preserve systolic function and increase stroke volume, and narrow autonomic changes that are mostly characterized by an increased vagal tone. So what is important to highlight is that in the context of the heartless heart, there is an homogeneous dilatation of both right and left ventricle. In other words, the heartless heart is a balanced, enlarged heart. It's very important when we have to differentiate chamber dilation versus cardiomyopathy. So differentiation is very important because it's crucial because of the potentially adverse outcome associated with cardiomyopathy in athletes. And on the other side, on the other hand, the possibility of misdiagnosis of pathologic condition requiring unnecessary disqualification from sport with financial and psychological consequences. So I would like to focus my presentation on the problem of differential diagnosis between right ventricular dilatation and arrhythmogenic right ventricular cardiomyopathy. So we know that there is a sizable proportion of highly trained athletes showing an increase in right ventricular cavity dimension and or right ventricular arrhythmias, which unavoidably raises the question of differential diagnosis with the right ventricular cardiomyopathy. The problem of differential diagnosis is particularly challenging, particularly difficult for the subgroup of athletes, of highly trained, top-level athletes showing morphofunctional right ventricular changes and or electrocardiographic changes falling into the gray zone, the gray area between athlete's heart and arrhythmogenic right ventricular cardiomyopathy, considering the right ventricular dilatation. Right ventricular cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, is a genetic disorder of the right ventricle, predominantly affecting the right side of the heart in terms of fibrofatty replacement of the right ventricular myocardium, and most often manifests clinically with the ventricular arrhythmias of right ventricular origin and with the left bundle branch block morphology. We know that currently the diagnosis is based on electrocardiographic features, mostly tuberous inversion that leads to exploring the right ventricle, arrhythmias, ventricular arrhythmias with the left bundle branch block morphology suggesting the origin from the right ventricle. Most importantly, morphofunctional right ventricular abnormalities that can be detected by echo, MRI, or angiography, and in vivo by tissue characterization of myocardium showing fibrofatty replacement. So we know that this condition is genetic, is familiar in 50–60% of cases. And we know the genetic background of disease that is this is a desmosomal disorder. In other words, usually is caused by genetic defects of gene encoding for desmosomal proteins such as plakophilin, desmocholine, desmoglein, desmoplakin, and so on. This is very important for the next discussion. So currently, the diagnosis is based on international task force criteria encompassing a group of abnormalities, family history, ECG, depolarization, and repolarization abnormalities, arrhythmias, global and or regional right ventricular dysfunction, and tissue characterization of the myocardium. To diagnose the disease, we need two major criteria, one major and two minor, or four minor criteria together. These criteria have been recently revised with the aim, mostly with the aim to provide molecular genetic criteria for diagnosis and to provide quantitative criteria for right ventricular dilatation dysfunction by imaging techniques, and most importantly by histopathologic changes at the endomyocardial biopsy. So compare with arrhythmogenic right ventricular myopathy, the changes in the right ventricle consistent with athlete's heart are characterized by the symmetrical behavior. In other words, the dilation in the right ventricle is symmetrical compared with the left side, the left ventricle. It's characterized by the preservation of ventricular function, right ventricular function. It's characterized by the absence of fibrosis, and is characterized by the fact that it's an acquired and reversible condition compared with the arrhythmogenic right ventricular myopathy that is a genetic disorder. So recently, the Belgian group has proposed, has reported a subgroup of endurance athletes that actually show right ventricular feature, right ventricular changes that overlap with those found in arrhythmogenic right ventricular myopathy. They advanced the concept of exercise-induced right ventricular cardiomyopathy. And this concept was based on the observation that there is a high prevalence of right ventricular involvement in terms of right ventricular dilatation and dysfunction in those endurance athletes presenting with ventricular arrhythmias. You can see here that 46 elite athletes with VT, ventricular tachycardia, were investigated in this study, and major arrhythmic events were recorded in 18, sudden cardiac death in 9, and all these athletes actually had an important right ventricular involvement, as demonstrated by the fact that 89% actually fulfill the task force criteria for diagnosis of arrhythmogenic right ventricular cardiomyopathy. Most importantly is that family history of LVC was documented, was present only in one of these athletes. In other words, this condition, according to this paper, is an acquired, is sporadic condition, is not familial. This is very important for the next discussion. So the author also tried to investigate the physiological basis for this extreme remodeling of the heart in the subset of endurance athletes. We know that at rest, the work requirement of the right ventricle is minimal because of the very low afterload. With increasing exercising, we have an increase of the systolic pulmonary pressure and the afterload of the right ventricle. And what is important is that there is a greater relative increase in the right ventricular wall stress that is a consequence of the afterload, greater in the right ventricle compared with the left ventricle. And this is account for some changes we can observe during the acute exposition of the heart to the exercise. The authors, the Belgian authors, the same authors, with a combination of echocardiographic and MRI observation, demonstrate that at the post-race setting, you usually have a reduction of end-diastolic and end-systolic right ventricular volumes, while left ventricular volumes, an increase of the right ventricular volumes, while left ventricular volumes reduces. And this accounts for a decrease of right ventricular ejection fraction, but not left ventricular ejection fraction. In other words, according to these observations, the right ventricle acutely suffer the exposition to exercise in terms of dilatation and acutely reversible right ventricular dysfunction with reduction of right ventricular ejection fraction. So this reduction of right ventricular ejection fraction is proportional to the intensity and duration of exercise, as you can see here by these graphs, according to the kind of sports and sport duration. So usually, this decrease in right ventricular ejection fraction is reversible, is transient, and there is a complete recovery just after the acute exposition of the heart. But the authors observed in a subgroup of athletes with ventricular arrhythmias that there was a reduction of right ventricular ejection fraction that was a chronic phenomenon. In other words, was not a reversible, but was a chronic, a stable result probably of the exposition to exercise. And they advanced the theory that the cumulative effect of a repetition of increased wall stress, right ventricular wall stress over the time result in a remodeling of the right ventricle, which may represent an erythmogenic substrate for life-threatening events. In other words, according to this theory, the sport activity may itself induce a right ventricular lesion and induce right ventricular remodeling with the right ventricular not only dilatation but also dysfunction. This is a revolutionary concept because the traditional concept is that exercise is associated with a reversible chamber dilation without functional reduction. So what about differential diagnosis of this extreme right ventricular remodeling of the heart described by the Belgian authors and arrhythmogenic right ventricular myopathy? You can see here the criteria, the diagnostic criteria, the revised diagnostic criteria for morphofunctional diagnosis of arrhythmogenic right ventricular myopathy. You can see here that morphofunctional diagnosis of ARVC is fulfilled in the presence of the combination between dilation of the right ventricle and or dysfunction of the right ventricle and, most importantly, regional right ventricular wall motion abnormalities. In other words, the most specific part for diagnosis, the most specific criterion for diagnosis is the presence of segmental wall motion abnormalities with segmental right ventricular dysfunction. This is very important because this is important also for in terms of major or minor criteria, this association, this combination. So this is important because we have to demonstrate, in order to perform diagnosis of arrhythmogenic right ventricular myopathy, the coexistence of dilatation and or dysfunction with regional wall motion abnormalities. So if you find a right ventricular dilatation, like in this case, you can see the very huge increase of right ventricular outflow tract diameter. First of all, you have to compare this diameter with the diameter of the aortic root. Because, we remember, we said that the most important feature of the athlete's heart is the symmetrical dilation. The symmetrical dilation is a balanced enlarged heart. So, if you compare these two diameters, you can see here that this is a paper published by our group, that in athletes, usually the mean value of this ratio is less than 1. Instead, in arrhythmogenic right ventricular myopathy patient is more than 1. In other words, there is a greater right ventricular dilatation compared with the left ventricular dilatation. So you can see here an example of an athlete with an increased right ventricular flow tract diameter, and you can see here that the ratio between the right ventricular flow tract and the aorta is 1. Instead, in arrhythmogenic right ventricular myopathy patient, you can see here that the ratio between the right ventricular flow tract diameter, 41 millimeters, and the aorta, the aortic diameter, 32 meters, was 1.28. In other words, there was an asymmetric dilatation in favor of the right ventricle compared with the left ventricle. So this is the first thing to do in order to for differential diagnosis. The second point is to look at the wall motion abnormality. In other words, a simple dilation is not enough for diagnosis of ARVC. So in other words, in this particular case of an athlete with an increased right ventricular flow tract, you can see here that the wall of the right ventricle or the right ventricular flow tract moves regularly. There is a preserved wall motion in this area. Instead, you can see here in this arrhythmogenic right ventricular cardiomyopathy patient with a right ventricular flow tract of 41 millimeters that there is an akinesia. Akinesia is completely akinetic, the wall of the right ventricular flow tract. In other words, in this particular case, you can prove the association between dilation and a wall motion abnormality. So of course, you have to look for other wall motion abnormalities in other region of the so-called triangle of dysplasia. That means the inflow tract just below the tricuspid valve, the apex, and the right ventricular outflow tract. So by echocardiography, you usually can demonstrate this is a normal heart and this is a heart from an ARVC patient. By the echo, you usually can demonstrate just hypokinesia or akinesia of the right ventricular wall. In this particular case, you can see here, this is the inlet of the right ventricle. You can see here that there is akinesia of this region, the posterior lateral region below the, and you can also better demonstrate the wall motion abnormalities by three-dimensional echocardiography. While the MRI allow you to demonstrate actually bulging or dyskinesia. Like in this case, look at this right ventricular aneurysm. The bulge just below the tricuspid valve. In this particular case, you can observe an aneurysm of the right ventricular outflow tract and the inferior wall. And again, you can observe here aneurysm of the apical regions. So MRI should be performed when you suspect the presence of a right ventricular cardiomyopathy because the increase of the right ventricular flow tract, the increase of the right ventricular diameter is associated with a reduction of the ejection fraction and is asymmetrical. And you can demonstrate more clearly the presence of bulging or aneurysms. So the presence of the arrangement of trabeculations, some structural abnormalities, or circulations, like in this case, can be useful for refined diagnosis, while the hyperreflective moderator band is a non-specific finding. So what about demonstration of fibrosis? So what can actually distinguish ARVC from athlete start is the presence of a reduction of ventricular function and the presence of fibrosis, because fibrosis is typical for cardiomyopathy. So according to the task force criteria, histological diagnosis of arrhythmogenic right ventricular cardiomyopathy is fulfilled when there is a critical reduction of residual myocytes. This is a very important concept. It's not the presence of fat or fibrosis. It's the amount of myocardial atrophy that is crucial for diagnosis. So in other words, the fibrofatty replacement of the myocardium is a replacement type fibrosis. That implies that you have a loss of myocardium that is replaced by fibrofatty tissue. So this is an example of biopsy for a patient with ARVCD. You can clearly show that the amount of residual myocytes is very low, consistent with the major criteria for histopathologic diagnosis of ARVCD. So we have the possibility to investigate this scar tissue in vivo, for example, by magnetic resonance with the late gadolinium enhancement. And we know that in arrhythmogenic right ventricular cardiomyopathy, you can demonstrate the presence of myocardial fibrosis in terms of late gadolinium enhancement of the right ventricle, but most often also by an associated spotty involvement of the left ventricle. So in other words, you can demonstrate the presence of largely replacing fibrosis by histological examination, but also by late gadolinium enhancement. So what about fibrosis in highly trained top-level athletes? This is a paper always from the same group for Belgium, showing the typical pattern in a subset of endurance athletes of fibrosis. You can see that usually the fibrosis, the late gadolinium enhancement, is confined to the junction between the right ventricle and the left ventricle. It's a completely different pattern. So they didn't find never right ventricular involvement. And very occasionally, exceptionally, the involvement, a stria in the left ventricle that may be more consistent with a myocarditis. Why this particular pattern of fibrosis at the junction between right ventricle and the left ventricle? Because this LG, late gadolinium enhancement pattern, resembles that described in patients with pulmonary hypertension. This is typical for increased right ventricular pulmonary hypertension, in whom the increased intraventricular wall stress caused by right ventricular pressure overload may cause a myocardial injury at these sites. In other words, there is an overlap of this particularly extreme remodeling of right ventricle observed in a subset of athletes and pulmonary hypertension, because probably the mechanism, the underlying mechanisms overlap. And the significant increase in the pulmonary pressures demonstrated in trained athletes during intense exercise suggests a similar physiological stress, though only transient. So there is another evidence that was claimed by the Belgian authors in order to support the concept of an acquired exercise-induced right ventricular cardiomyopathy. They report the findings obtained in this rat model of endurance activity that was developed in Spain, Barcelona. And you can see here that in exercise rats, the Spain authors demonstrated that there is a progressive increase over the time of the myocardial fibrosis. So in other words, in experimental animals, they actually found myocardial fibrosis that increased over the time with the time of exercising. But what is very important is that this kind of fibrosis, of course, the first problem is to translate experimental animal findings to humans. But the second problem is that this fibrosis found in these experiments is this kind of fibrosis. This fibrosis is not replacing the myocytes, it's in between myocytes. So it's the so-called interstitial fibrosis. It's not replacement type fibrosis like that we usually find in arrhythmogenic right ventricular cardiomyopathy. You understand, it's a completely different histologic pattern. So finally, I'd like to address the problem of family history, of genetics. So according to the new guidelines, the identification of a pathogenic mutation categorizes as associated or probably associated with RVCD in patient under evaluation is a major criterion for diagnosis of arrhythmogenic right ventricular cardiomyopathy. So now we know that this disease is the desmosomal disease due to defective genetic defects of the gene encoding from desmosomal proteins. And these desmosomal proteins include plakophilin, desmoplakin, plakophilin, and so on. So the demonstration of the genetic defects, of course, support the diagnosis of arrhythmogenic right ventricular cardiomyopathy. But what is extremely important, please, this is a very important point. Not only in arrhythmogenic right ventricular cardiomyopathy, but also in other genetic conditions, like such as, for example, channelopathies, usually the prevalence of the positive genotyping, that means that the screening for a mutation is positive, is much higher, the prevalence, in the familial disease compared with the sporadic one. In other words, For example, in this important paper on circulation, the prevalence of mutation in the plakophilin 2, it is the gene encoding for one of the most important protein involved in the pathogenesis of the arrhythmogenic right ventricular myopathy, is 70% in the familial ARVC. That means an index case with the proven family members affected by the disease. In other words, you have to actively screen the family and to demonstrate the presence of other affected members in the same family. So this is a true familial disease. So in other words, if you have a sporadic disease, 50% of ARVCD are sporadic. 50%. 0% of positive genotyping. This is very important because the Belgian authors claimed in favor to support the idea that the subgroup of athletes didn't have actually arrhythmogenic right ventricular myopathy, but actually had the new condition that was exercise-induced that was acquired. They claimed that the prevalence of desmosomal mutation found in their cohort was fewer than that expected for arrhythmogenic right ventricular myopathy. They said, okay, in ARVCD, 40% of ARVC patients actually have a positive, the presence of a desmosomal mutation. In our cohort, only 12.80%, only 13% actually had the positive genotype. So this cohort is not arrhythmogenic right ventricular myopathy. But they didn't consider that this is not familiar ARVC. It's a sporadic ARVC. Only one case, you remember in the first slide I showed you, only one case was a familial, had the positive family history. So the cohort was a cohort of sporadic morphofunctional right ventricular abnormalities, and the expected prevalence of mutation is probably much lower than 13%. So in conclusion, long-term extreme right ventricular pressure and volume overload of endurance sports may account for an exercise-induced right ventricular dilation and dysfunction. The available data suggest that this condition show pathobiologic and clinical features completely different from arrhythmogenic right ventricular cardiomyopathy. Whether unrecognized defect and or polymorphisms may predispose a subset of athletes to development of an RVCD-like phenotype, a result of their hard exposure to intense endurance sports, remain to be established. Thank you for your attention.